Test 1 2 1 2 test testing 1 2.
Cirrhosis Medical Network and St. Vincent's for organizing this and having me here. I'm excited to interact with you all on this very common problem, which we see very commonly, and I think you in your practice also, of cirrhosis, and how we can make a difference in terms of managing their complications and prevent readmissions and improving their long-term outcomes. So here are the educational objectives. So we will go over some of the complications, understand what these complications are from chronic liver disease and cirrhosis. We'll talk about, in specific, about hepatic encephalopathy, because that drives most of the morbidity, if not the mortality, from complications. We'll talk about some of the economic and social issues on the patient, on the caregiver, before transplant, after transplant in these patients, and also how we can understand hepatic encephalopathy as a driver for readmissions, and what we can do and make a difference to these patients to prevent these readmissions. So we all know that whenever there is a chronic liver disease from any etiology, fibrosis and cirrhosis is the final pathway before patients develop complications or decompensation of liver disease, which could be liver failure or other complications which we will look at, including hepatocellular carcinoma, and many a times we'll talk about liver transplantation at an appropriate time as a life-saving treatment for these patients. Well, how common is cirrhosis? Let's talk about that. Well, the number is over here, so it's about 0.25% of the general population in the US have cirrhosis, and this is the cirrhosis we talk about, what is evident or overt or symptomatic, or what presents to you in the hospital. That's about 0.25%, which turns out to be about over 600,000 individuals across the US who have liver cirrhosis. The problem is that 70% of patients who actually have cirrhosis, and this data comes from autopsy studies, and the autopsy studies say the prevalence is about 1%. So it turns out about 70 to 75% of these individuals never know that they have liver cirrhosis. They're walking with cirrhosis. And one of the reasons is that the findings or the symptoms or the signs may be so subtle that they may be very difficult to pick up in routine practice. And as you must have seen, many of these patients are worked up in primary practices, even with hematologists with thrombocytopenia, and this goes on for years, which actually is a manifestation, the call in, that the patient is having cirrhosis. Muscle wasting is another very subtle sign which may go on for years undetected. And then obviously liver enzyme abnormalities is another way which can go completely asymptomatic, undetected for many, many years. And two of the things I listed over here, and these are important, and that is alcohol use and diabetes. So patient may not be drinking alcohol at the moment, but if it is a prior history of alcohol use, especially in the last 1 or 2 years, if the patient has been drinking heavily and the patient shows some findings which may be very subtle, you may like to correlate that something is going on bad in the liver. And we all know the problem of like an epidemic coming in the US of diabetes and obesity driving the most common problem of fatty liver disease, which is going to become number one liver disease, if not today, at least in the next 2 or 3 years. So if you are standing here in 2020 or 21, I think we will be saying that very confidently, that fatty liver disease is the number one cause of cirrhosis in the US, practically all over the world. So when we talk about cirrhosis, we talk about complications, and other word for complication is when the patient shows a decompensation, and what that decompensation is we'll see in the next few slides. And it's important to separate these two, compensated and decompensated. You can see on the slide that patients who have decompensated cirrhosis, which is the bottom line here, and this is about 10 years of follow-up, which is a prospective study compared to the compensated cirrhosis. Clearly you show right in the first year their survival is clearly separate. from those patients who have compensated cirrhosis. And here is how these patients can decompensate. So these patients can have varicose bleeding, that's a decompensation, ascites or hepatic hydrothorax, that's a decompensation. There could be associated complications with SBP or hepatorenal syndrome. There could be lung complications with hepatopulmonary syndrome or portopulmonary hypertension. And finally, jaundice, coagulopathy, low albumin, and liver failure. And speaking about encephalopathy at the end, because that's, I think, the most common complications of patients with cirrhosis. Not only most common, but I think the most important. And right from here, we'll talk about encephalopathy more than anything else in terms of decompensation. So what is hepatic encephalopathy? And if you look at this definition, which was evolved in 2014 by the American Association for Study of Liver Disease in a guideline document, where they say it's a brain dysfunction. So it's a very non-specific definition. There's nothing specific about it. So it's a brain dysfunction, and as the word implies, you have to have a hepatic disorder. So the patient has a chronic or acute underlying liver disease with a brain dysfunction and can manifest. Look at the spectrum of manifestation. Could be neurological or psychiatric manifestation, and it can range from completely subclinical to the extent that patient may forget certain things, may forget that he put his money into the bank account and the next day doesn't know whether he put his money in the bank account. That kind of subtlety could be, and the patient may have hepatic encephalopathy. And finally, it could be a very obvious manifestation with confusion and to the maximum extent of coma. So a little bit talking about mechanisms and pathogenesis of hepatic encephalopathy, and we all know that ammonia drives the most important neurotransmitter or a chemical which drives hepatic encephalopathy. However, there are some other chemicals and neurotransmitters which drive and involved in causing hepatic encephalopathy, and the important one is glutamate. And also, there have been studies showing that these patients have a very subtle inflammatory, systemic inflammation going on throughout the body, which increases the cerebral blood flow. Cytokines are high, and all this cause swelling of the astrocytes, or the neural cells, and lead to increased intracranial pressure and leading to hepatic encephalopathy. So it's multifactorial, but the most important component which drives it is ammonia. And how ammonia gets into the body is in this slide. As we know, that ammonia comes from the gut. So it could be the food load, that's the most important, or the dying cells of the gut, which release proteins, and the proteins get converted into ammonia, and the ammonia gets into the portal circulation, and it can bypass the dysfunctional liver into the systemic circulation, because ammonia normally in all of us, we are all eating this protein food, and this ammonia which is released after a couple of hours, our normal liver takes care of it, converts it into urea. Urea gets out into the urine, and we don't have excessive ammonia in the body. However, patients who have liver disease and cirrhosis, their livers are not working, and this ammonia gets into the systemic circulation and causes problems. And more importantly, these patients with cirrhosis have portal hypertension and development of these collaterals. So the portal circulation is directly shunted into the systemic circulation because of these collaterals and varices, and therefore ammonia bypasses even the liver to get into the systemic circulation and cause increase in elevation of ammonia. So if you understand this, so even patients may not have hepatic encephalopathy symptoms, but the ammonia levels may be high, and that's important to understand. So how the hepatic encephalopathy, we talked about, it could be subclinical or it could be various stages, and the stages were given by this classical West Haven classification from Connecticut many, many years ago, I think 40, 50 years ago. And this classification still stands, which could be stage 1, which is very, very subtle, and it could be even covert hepatic encephalopathy, very difficult to recognize. It is the stage 2 when the patient is confused and you clearly know that the patient is having subabnormality, and onwards it is the overt hepatic encephalopathy. So it could be covert, which is minimal or stage 1, to an overt hepatic encephalopathy, which is stage 2 to stage 4. And important thing is, as the severity of hepatic encephalopathy goes, the cognitive dysfunction of the patient worsens as the encephalopathy stage goes higher and higher. And this is most of a semantic, but I think it's relevant, especially for residents and fellows who admit patients on service. And this is way of communicating in a medical community, in a literature, or when you're presenting cases, is what kind of hepatic encephalopathy you're talking about. So if you focus on the row 1, which is A, B, and C, so type A is something which develops in the setting of a fulminant hepatic failure or acute liver failure. So A. C is one which develops in the setting of cirrhosis, and B is which develops after doing a TIPS or a shunt procedure. And the grade we talked about, minimal to stage 1, 2, and 3, and 4, and then we divide them into covert and overt. I told you minimal and stage 1 is a covert, and 2 to 4 is an overt hepatic encephalopathy. Patients may come, and we all see, can come like an episodic recurrent. You treat the patient, becomes normal, goes home, gets back again after a few weeks with another episode. So it is what is called recurrent hepatic encephalopathy. And there may be patients where they never come out of that. They always remain some level of confusion. It could be a persistent hepatic encephalopathy. And then there could be a spontaneous episode, and more often it is a precipitated episode by some kind of precipitant, and we'll talk about what those precipitants are. Here are those. So we talked about ammonia as a source. So ammonia comes from blood. So blood has a lot of proteins. So GI hemorrhage, dietary proteins. So you see, all of you, I think we at UAB expect, and we are always prepared for admissions for hepatic encephalopathy around Thanksgiving, Christmas, New Year, because that's the time these folks take a lot of protein load. The turkey goes in, and patients come into with hepatic encephalopathy. Some of the electrolyte imbalances are important. Hypokalemia is common. Many times these patients, and that's what you tell these patients, is when they take their lactulose, and we'll talk about that, is to have those 2 or 3 bowel movements to have the effect of the medication. And when they don't take that enough lactulose and they get constipated, gets precipitated with ammonia. Shunts, we talked about TIPS and spontaneous shunts, and some of the drugs which are benzodiazepines, opioids, and they should be screened when the patient comes with hepatic encephalopathy, and make sure, are you dealing with hepatic encephalopathy or is just a drug overdose? Infections is a big one, SBP, so it's a low threshold for suspicion. Any patient who comes with hepatic encephalopathy, if they have ascites, tap them and make sure they don't have SBP. And finally, some of the rare ones like underlying hepatocellular carcinoma, portal vein thrombosis, and sometimes this could be something else. So always in the radar, as I said, the definition and presentation of hepatic encephalopathy is not specific. Even the signs are not specific. Those flapping tremors you see on the patient are not specific. Any kind of brain abnormality can cause the patients to flap. So you should always have this think in your mind that, is this patient not having something else, like he may be having subclinical seizures, meningitis, stroke. Those kind of differential diagnoses should be running through your mind if the patient is not waking up after doing everything with the patient. So this is why that slide was important, is how the ammonia gets into the body. Is that a patient may be completely normal, but their serum ammonia may be high because they have these all collaterals, and the ammonia formed in the gut can get into, through these collaterals or shunts, into the system, raising the serum ammonia level. And I will read this for you. Increased blood ammonia that does not add any diagnostic, staging, or prognostic value for hepatic encephalopathy in patients with chronic liver disease. Okay? So the message here is, or the take-home message is, please do not do serum ammonia testing in these patients unless it is really indicated. The patient is all right, ammonia could be high, you don't have to treat these patients. So that's what, in routine practice, ammonia levels are not done to monitor these patients for hepatic encephalopathy, because the symptoms and levels of ammonia, they don't go hand in hand, except in acute liver failure, because there are no shunts in that patient. So in acute fulminant hepatic failure, whatever ammonia levels are you seeing is because of the dysfunctional liver. There is no shunting here. And therefore, in acute liver failure, serum ammonia levels have a prognostic value, and many studies have shown level above 170, 175. One study showed 200. it predicts a bad outcome of this patient, because there it is directly related to the severity of liver dysfunction and how bad the liver is failing. So now moving on to the treatment, which is the most important part here of hepatic encephalopathy. The goals of treatment are, there are 4 goals here. Number 1, because these patients are altered, so you have to provide a supportive care, their nutrition, their skin care, and all that stuff. I'm not going to go into those details. Try and remove a precipitating factor. So if this is a patient who is a cirrhosis patient, recognize the precipitating factor. We talked about that list of precipitating factors, starting from drugs to infections to cancer to portal vein thrombosis. Go through all that list and make sure you treat the precipitating factor. And then finally, a specific therapy for hepatic encephalopathy, which we will talk about, and then how to prevent another episode of hepatic encephalopathy. So those are your 4 goals when you see a patient with hepatic encephalopathy. And here are the lists of medications which are used often in the treatment of hepatic encephalopathy. Top 2 are the ones commonly used, lactulose and rifaximin. Bottom 3 are alternatives to rifaximin if rifaximin is not available for some reason, the patient cannot afford it, insurance issues and things like that. And then you can chip with neomycin, metronidazole, or vancomycin, all 3 as effective as rifaximin, but they have side effects. They're not as safe as rifaximin. So how the lactulose? Why not? Lactulose is a laxative, so why not just give them Miralax and treat these patients? Lactulose has a unique action. It is an unabsorbed or disaccharide. It's a sugar which is not absorbed in the stomach, in the intestine, and as it is, it gets to the colon. And in the colon, by the bacterial action, that's where the bacterial action converts this lactulose into lactic acid and releases those hydrogen ions. So the H ions which are released from the lactulose by the gut bacteria in the colon, that traps the ammonia as ammonium. So ammonia by itself is not soluble. Once it combines with that hydrogen ions, makes it soluble, flushes out into the stool, and that decreases the serum ammonia level. And that's why the lactulose has that unique action and causes a very specific action in patients with hepatic encephalopathy, which is not provided by other laxatives, including Miralax. And here is the data that lactulose for hepatic encephalopathy, and you will see the top curve, and it's a meta-analysis of many, many studies. In patients with, you may not see that very, the font sizes, I don't know whether you can, I think here you can. So if I can show you here, the top one is for the patients who are overt hepatic encephalopathy, so there are about 5 or 6 studies. This is a patient with minimal hepatic encephalopathy, there are about 9 or 10 studies. And this is for prevention of hepatic encephalopathy, and there's about 5 or 6 studies again. And as you can see, for each one of those, the effect size is very, very significant in favor of lactulose than placebo in preventing another episode of encephalopathy, treating minimal hepatic encephalopathy, or treating overt hepatic encephalopathy. So in all corners, lactulose is a winner and is the drug of choice for, or the first drug of choice for hepatic encephalopathy. So what are the practical considerations when you use hepatic encephalopathy treatment with lactulose? We know that it is given orally, except obtunded patients where it has been used very effectively in a rectal enema fashion because the mechanism of action is in the colon. So if you directly give in the colon, it works as good as taken by mouth. But this is only given to patients who are obtunded, and you cannot give it by mouth, or patients who have ileus or obstruction of the intestines. Important thing is that it is not. How many of you have taken lactulose here? Anybody? For many reasons, any reason, constipation or anything. Well, I have taken it one time, and it is extremely, extremely unpalatable, and patients would tell you that it's very difficult to take. So that's the major problem with lactulose. And also it causes a lot of abdominal distension, cramping, diarrhea, and that's why patients who are going for liver transplantation, and we know this patient in 24 hours will be on the table, we try to avoid giving them lactulose even if they are encephalopathic, because their guts are distended. Surgeons don't like it when they go in changing that liver, and we try to avoid that when these patients are near their transplantation and the organ is available. What about rifaximin? So rifaximin is a minimally absorbed oral antibiotic, so it's not absorbed. It's a broad spectrum. It's given as oral medication in a dose of 550 milligram twice daily. And it has no drug-drug interactions. It's a very safe medication. And you don't have to adjust the dose in patients who have bad liver disease, even with liver failure, whatever their MELD scores are, and their renal failure. So you don't have to alter the doses, and you continue the same dose of 550 milligram twice daily. So this was the pivotal study almost 10 years ago, published in New England Journal of Medicine, and the lead author was from UCSF, where you can see the rifaximin as compared to placebo over a period of about 7 months, clearly shows benefit, almost 60% risk reduction of hepatic encephalopathy episode once these patients were rifaximin. Important thing is that 90% of both the arms, rifaximin and placebo in this trial, were on lactulose. So clearly the recommendation came out as rifaximin as an add-on therapy to lactulose, not as a standalone treatment. So rifaximin as of today is an add-on treatment to lactulose once the patients fail lactulose and they have a breakthrough episode of encephalopathy. Then you add on rifaximin to lactulose and not a substitute to lactulose. But rifaximin is an important medication, and I'll show you some of the data. And this slide shows you the data on how hepatic encephalopathy impacts not only the patients but also their caregivers. And this is the 3-year data from one of my friends who did a very nice study, just taking interviews of these caregivers who were taking care of these patients for almost 3 years. And clearly you can see almost 50% of these caregivers were in debt at the end of 3 years, and almost 10% declare themselves bankrupt. So it's a major financial issue in terms of how it impacts the caregivers, and I think I'll show you some of the data to the same financial economic impact on the hospitals also. And this caregiver burden continues to increase as you grow from minimal encephalopathy to stage 1 encephalopathy and very overt encephalopathy, and this burden keeps on increasing, and that is no brainer. As the patients are becoming more sicker, the burden will increase. What about the patients? So we talked about cognitive dysfunction when the hepatic encephalopathy goes and increases in severity, and this data shows you how the cognitive function of the patients can be impacted. And this is one of the learning tests or number connection test which patient has done at the first evaluation, and then this same test is repeated after about 2 weeks on a second evaluation. As you can see, patients on the left who never had an episode of hepatic encephalopathy, you clearly see their score and performance gets better. On the right-hand side, you see patients who had a previous episode or who currently have encephalopathy, their lines are flat. So there is no improvement or maybe a decrease in their performance in between the 2 evaluations, clearly showing you how it impacts the cognitive function of patients in terms of learning from the test and giving a right answer at the next time. Not only that, this problem persists even after transplantation, and this is a paper which showed that there is a decline in brain volume in patients with hepatic encephalopathy history prior to liver transplantation, which is shown in the blue, compared to patients who never had history of encephalopathy prior to liver transplantation, shown in orange. And as you can see, the decline in the brain volume is much more in patients who have a previous episode of encephalopathy. And this translates into how their recovery happens after liver transplantation. And as you can see, the lower curves in orange are the patients who have previous episode of encephalopathy, and the upper lines are the patients who did not have a previous episode of encephalopathy. Although both the patients are improving their attention span, their memory, and their executive function, but you can clearly see those who have encephalopathy history, they're not as good as recovery as patients who had a previous history of encephalopathy. So not only on the caregivers, on the patients, but also on the hospital. So here is the data to show you how hepatic encephalopathy can drive hospital readmissions. And this is a study from one of my friend, Michael Vogt from Michigan, who published about almost 6 years ago from their own center. So they looked at 400 patients and our average follow-up, a median follow-up of about 200 days, 7 months. And you can see that within a year overall, readmission rate was almost 70%. So once these patients went home after an admission for hepatic encephalopathy, look at 70% overall with a median time of about 7 months readmission. If you look at within a week, almost 10 to 15%, within a month, almost 30%. So within a month, 30% are getting readmitted. And why is that important? We'll talk about to the hospitals and providers. And when they broke down into causes of readmissions, and the blue bars you see all-cause readmissions, and the green bars are the ones which are from the hepatic encephalopathy. So if this is the all-cause, and this is the hepatic encephalopathy, you can see 2/3 or more of all the readmissions are due to hepatic encephalopathy. So that's such a major problem. So they were admitted for all kind of reasons with cirrhosis, bleeding, ascites, encephalopathy, but encephalopathy drove 2/3 or more of these readmissions. And when they looked at in another way, looking at a regression model, although every complication was driving the readmissions at 30 days, hepatic encephalopathy was the strongest. Almost threefold risk of readmission if the patient was admitted for hepatic encephalopathy. And similar data for 90-day readmission. And these are some of the slides I'm going to show how rifaximin can make a difference in patients who have had a breakthrough encephalopathy on lactulose. Clearly on the left you see patients who were put on rifaximin in the green bars, and patients who were not on rifaximin, just on lactulose in the blue bars, you can reduce the number of hospitalization if they are added on rifaximin. On the right you see even that single hospitalization, the number of days the patient is in the hospital is reduced. So not only number of hospitalizations, but how long the patient is going to stay in the hospital is also reduced by rifaximin add-on once they have a breakthrough episode on lactulose. So it translates into a total time patient is in the hospital over a year, significantly down by rifaximin, and this translates into hospital charges. So although rifaximin is a costly medication, but once you put these patients on, ultimately the charges in the hospital, which the patient is spending, comes down significantly. That's a major impact on hospitals and providers. And this is another study where you look at the similar data, and you can see the time 0 is the time when these patients were started on rifaximin. So anything on the right is what happened to these after adding rifaximin, and anything on the left is what was before starting rifaximin. This is the number of hospital admissions. There you can see there's an increase in the number of hospital admissions before they were put on rifaximin, and there is a decrease in the number of admissions after they went on to rifaximin. And similarly, the length of stay, increasing length of stay, decreasing length of stay after these patients went on rifaximin. So clearly, there are multiple ways I can make a point that how rifaximin is important in treating these patients hepatic encephalopathy. And this is another important slide to show how it is important not only for the patient and caregivers, but also important for the hospitals and providers. And this slide shows you 11 conditions. 7 of these are the diagnosis codes which the patient gets admitted for, and 4 of these are the hospital-acquired issues. And I'll read out for you: the acute myocardial infarction, heart failure, COPD, and pneumonia. So those are the 4 conditions. And then the hospital-acquired conditions are CLABSI, MRSA, COTI, C. difficile, sepsis, falls, and pressure ulcers. Now, why these 11 conditions are important? Because all of you know these are important because the CMS looks at these very carefully as a driver of readmission, and accordingly reimburses the hospitals and providers. So that's why these 11 conditions are important. Hepatic encephalopathy is not in this list, but if you look at the data, hepatic encephalopathy in 40% of the time is associated with one of these 11 conditions. So indirectly, hepatic encephalopathy may be affected in terms of how CMS reimburses hospitals and providers. And therefore, it is not only important for social and financial standpoint, but also to the hospital in terms of how they are going to be reimbursed and how the providers are going to be reimbursed. So why, if we have good medications, you know, rifaximin is an excellent drug I showed you, lactulose is acts beautifully, we have cirrhosis management has improved over years, why these patients are coming on readmitted? What are the reasons? Okay. Well, some of the reasons could be just related to the patients. The patients are frail, they are malnourished, their home situation is not good, so those drive readmissions. They have psychological comorbidities, and it's important when these patients came to the hospital with hepatic encephalopathy, and we talked about it, that you go through their medications, medication reconciliation, and those unnecessary medications, if they are on benzodiazepines, on opioids, which can cause all these problems, they should be taken care of. A polypharmacy should be avoided. And I think the most important factor is the system-related factor, how you take care of these patients in the hospital. And many of these patients, there may be an opportunity, they are not transplant candidates, they have bad liver, they are in liver failure, an opportunity to discuss goals of care before the patient goes home so that you can appropriately transition these patients to a palliative care or somewhere and prevent the readmissions. And finally, if those patients who you think are making to the transplant or they are salvageable, how these patients are transitioned to an outpatient in the clinic setting, their discharge instructions, communication issues, transportation issues. Many of these patients may not have transport to come to the clinic to show the provider. So I think the discharge instructions, how the nurses, residents, fellows, providers, faculty, how these instructions go to the patient, because if you remember, cognitive dysfunction, patients are not going to remember your instructions. So the caregivers have to be conveyed and identify who's going to provide care to the patient when the patient goes home, and that caregiver has to understand how the lactulose needs to be given, what medication needs to be given. That's, I think, a very important factor. And this is important also, one of the studies showed that 60% of the times, patients were not communicated what was supposed to be communicated to them at the time of discharge, and that drives the readmission rates of these patients to the hospital. And that is one of my last slides to show you in a scientific way how the system is important in getting the things right and preventing readmissions. And I'll spend 5 minutes on this slide to make that point. So this is a study where they looked at 3 phases, and these are the causes of readmission. So there is a control phase where patients are getting admitted, getting discharged, that common way the hospital was doing. And then they had a paper checklist. Another phase where they had a paper checklist. And finally, that paper checklist got transferred into an electronic fashion into the computer. So unless you answer a particular question, it will not let you move to the next. So very, very rigid way, the electronic form. So these 3 different phases, and then the patients looked at the reasons for readmissions. If you focus on the blue bar, which is encephalopathy-driven readmissions, so here about 50%, down to 25%, down to 10%. So clearly telling you, if you make your system right, so do everything, okay, this has been done, yes, move to the next. This has been done, yes, move to the next. This has been, so ultimately when the patient goes home, you made sure everything has been taken care of, and this has reduced the readmissions significantly from 50% down to 10%. And many of the hospitals are now adopting this policy after this paper came 4 or 5 years ago, impacting 30-day readmission rates from hepatic encephalopathy. So this is the conclusion slide here. So I think we saw a lot of data on that hepatic encephalopathy is an economic and social burden, very common problem, not only to the patients, caregivers, but also readmission to the hospital. It's not completely benign complication. It can affect cognitive not only before transplantation, but can also leave a mark, an impression on the patient in terms of their dysfunction of brain after liver transplantation. So before I close, I will go over some of the questions which we went over, and the answers were already there in the slides somewhere. So it's kind of interaction with all of you. I'll read out the question for you, and maybe I'll ask you to raise your hands to a particular answer. So increased blood ammonia alone does not add any diagnostic, staging, or prognostic value for hepatic encephalopathy in patients with cirrhosis and chronic liver disease. A normal value calls for diagnostic reevaluation. So how many think this is a true statement? Okay, almost half. How many think it's a false statement? Nobody. That's excellent. So the point is made. So clearly, increased blood ammonia has no value as long as the patient is doing well, and we don't normally monitor that in routine practice. Okay, 21-year-old patient came to the hospital due to Tylenol overdose, develops coma, and now an encephalopathy from liver failure. What type of hepatic encephalopathy is it? Type A, how many think it is type A? Okay, so 5 hands. Type B? Nobody. Type C? 4 hands. Well, type A is that the patient comes with acute liver failure. Type B is the one which has in shunt, and type C is with cirrhosis. So this patient doesn't have cirrhosis. It just comes with an acute Tylenol overdose, develops fulminant hepatic failure, encephalopathy. So it's type A. Okay, question 3. Which are a precipitating factor for hepatic encephalopathy? Hypokalemia, constipation, TIPS, SBP, all of the above. How many think it is all of the above? Okay, so most of the room thinks it is all of the above. All right, question 4. Which factors contribute to pathogenesis of hepatic encephalopathy? Ammonia, glutamate, inflammatory cytokines, nitric oxide, all of the above. How many think it is all of the above? Yeah, I think we saw that everything contributes to pathogenesis of hepatic encephalopathy. Now, this question, rifaximin provides which of the following benefits in the treatment of encephalopathy? So it prevents recurrence, it reduces hospitalization time, it reduces number of hospitalization, we saw that. It reduces resources from the hospital, so it reduces charges. So it's all of the above. So it helps everywhere. Okay, which one? What is the most common logistic reason for readmission here? Patient-related factors, medical factors, system-related factor. How many think it is a system-related factor is the most important one? Okay, great. Okay, so I think that's the right answer. System-related factor is the most important factor driving. Proportion of patients with decompensated cirrhosis who are admitted at 30 days after index discharge is 5%. How many think 5% at 30 days? How many think 15%? How many think 30%? Great, excellent, point is made. So it's 30% at 30 days. And last is, post-liver transplantation, there may be a decline in cognitive function in patients with history of overt hepatic encephalopathy. True or false? True, great. Okay, thank you all. And if there are any questions which I may have left out, you have anything to ask for, I'm here. Anything. So, thank you very much.